So today I want to spend just a moment talking about the treatment of diabetes. We really have or take a three-legged approach when we're treating these persons that have either type 1 or type 2, especially type 2 since we see so much of type 2 diabetes. The three-legged approach would be that we intend to, first of all, improve their dietary habits, and the second part of that would be to add exercise to their day. And then the third part would be medication. Medication is what we're going to concentrate on here today. Things that you need to know before we get into the medication. One, we also monitor blood glucose levels on both your type 1s and type 2 diabetics. And so you're looking for a fasting blood sugar of somewhere between 70 to 130 and a 2-hour postprandial, which means 2 hours after the meal. We are looking for their blood sugar to be less than 180. That would be the numbers that we're looking for there. The other one is the hemoglobin A1C. And the hemoglobin A1C is one that is drawn, it's a blood draw, and it is one that is measuring how their blood sugars look over a period of time. And we're looking for that to be somewhere under 7%. Once we get over 7%, the person has really at high risk for multiple other problems to be going on. All right, so on to insulins. Insulins, we have really about 4 basic types, and then we have a mix. So I'll start with the first one, and that one is the rapid-acting insulins. Rapid-acting insulins do exactly what they say. They act rapidly, like right now rapidly. Within about 15 minutes of giving them, and they're given either subcutaneously. We also see the rapid-actings are the types of, it's the type of insulin that will be in an insulin pump. They stay in the body about 3 to 5 hours after they're being Lispro, Novolog, Apidra. Those are the 3 main rapid-acting insulins, and they are given subcutaneously. All right, then we have our short-term insulins. Short-term insulins are going to be really easy to identify. The bottles have a big R on the side of it, and that R stands for regular. Our short-term insulins are regular insulins, and they would be like Humulin R and Novolin R. That insulin is given subcutaneously. It also is the only insulin that can be given intravenously. So if you're given IV insulin pushes in the hospital, you're going to be given regular insulin. It is also the insulin that is most used for what we call sliding scale coverage insulin, and I'll talk about that a little bit more in just a little bit. The third type of insulin is intermediate acting insulins, and these are given subcutaneous. The bottles are also easy to identify. They usually have an N on the side of it, a large N, when the N stands for NPH. So these are intermediate acting insulins. They usually act on the body in about 1 to 2 hours after given subcutaneously. The fourth type, long-acting insulins. These insulins were designed to slowly absorb over a 24-hour period. We have Lantus and Livomir, and they are given subcutaneously, usually once a day, but no more than twice a day, separated by 12 hours could they be given. And then the fifth kind would be the mixtures, and the mixtures are actually a mixture of an intermediate plus a rapid or short-acting insulin. Usually it's a 70-30, the 70 being the NPH part, the intermediate of that, 75-25, and then there is a 50-50 mix. Okay, so those are our insulins kind of in a nutshell for you. Then we'll move on to our oral anti-diabetic drugs for type 2 diabetes. Our insulin dependents would not be taking any of our oral anti-glycemics. The first drug is metformin, glucophage, and metformin is definitely the first line drug of choice for type 2 diabetes. It acts by decreasing the glucose production that is done by the liver itself, and it is often given along with insulin if the person is in need of more coverage to get their blood sugars under control. And also we also see metformin given a lot of times for pre-diabetic prevention to keep the person that is at high risk of developing diabetes from kind of getting to that point. Metformin is a PO drug. It is a large white capsule shaped tablet, and it is usually titrated when the person first starts it, titrated up to about a dose of about 2,000 milligrams daily. It is not the most, it just has a terrible taste to it, and it is one of those white powdery type tablets that really sticks to the tongue when you take it, so it's not a very pleasant taste. It doesn't leave a very pleasant taste when the person is taking it.
Side effects that we see with this, they're mostly going to be GI related things like nausea, vomiting. Weight loss is also one of the side effects. Metformin is one of the drugs that has been kind of played around with as far as for some of our weight loss doctors, because it does help with insulin resistance. All right, then we have the glycosides. They stimulate insulin release, and that is if the patient, to remember, if the patient is going to need insulin, then they have to stop the glyphosate. Unlike metformin, where they can take insulin along with the medication, with the glyphosate, they need to stop that drug before they're started on insulin. Side effects of the glyphosides. Well, side effect is going to be hypoglycemia. The blood sugar is going to drop. And then the opposite of metformin, we're going to see a possibility of weight gain with these persons. We have Actos. Actos is a glitazone, and it is the only glitazone that is on the market at this time. There have been a couple previous to it, and the FDA has removed those from the market because of different side effects and problems that were found, mostly cardiac in nature. But Actos is the one that is on the market now, and it acts kind of similarly to metformin. It is used a lot for insulin resistant persons, and it can also be given along with insulin. The side effects with it also heart problems, and we see weight gain sometimes with this one as well. We have a couple of other ones. We have Prandin and Starlix, and those are used a lot with the person that has real erratic eating patterns, because that can be given with the meal versus given something previous to the meal, and betting on them having a regular meal schedule. So we'll see those when we have people that have either poor eating habits or very erratic eating patterns. Side effects, hypoglycemia. See the pattern here? See the pattern? All right, we have Amylin and Byetta. Those two particular medications are a little different than these PO medications, and they are not insulin. They are not a substitute for insulin, but they are injectables, and they're given subcutaneously. The side effects that we see with those, nausea, vomiting, and weight loss would be the one with that as well. A few other little things, just a little tidbits on the side about insulin. Regular insulin is always going to be clear. When you hold the bottle up, it's going to be clear in the bottle. And NPH insulin is your cloudy insulin. You also will see your mixes will have a little bit of a cloudy tint to it because they are a mixture of NPH. So some of that is actually in the bottle. Our oral medications, we usually try to give those about 30 minutes prior to a meal. Insulin, when it is unopened, it could be stored at room temperature for about a month, and if it is in the refrigerator, it can be stored for up to 3 months. So most people, most hospitals, most places you're going to be at will still store their insulin in the fridge because it does extend the life of it. There are also very specific syringes designed for measuring insulin doses by the unit, and you need to choose the correct size syringe because they do come in varying sizes, debating on how many units you're going to have to give for the person. When giving subcutaneous injections to a person that has reduced or very little subcutaneous tissue, especially the elderly persons that have lost that layer, that fatty layer, be sure to try to pick a site that does have adequate tissue, because you're not going to have the same absorption through, if the injection becomes an intramuscular injection, that we intend for it to be subcutaneous. Injections that are given subcutaneous are going to be absorbed much faster than those injections that are given intramuscular. So just be real careful when you're giving these subcutaneous injections to people that lack that fatty layer of tissue.